I will present the global and regional situation to orient us, describe very briefly the polio response in the Middle East as a whole, discuss why Lebanon is still at risk and the key actions needed to keep Lebanon polio-free, and to second the comments of both previous speakers, why strengthening surveillance is crucial and why we need to look at OPV, oral polio vaccination, and IPV in Lebanon at this time. Polio eradication has been a massive success for medicine, a massive success for public health over the last 30 years. An ancient scourge is finally on the brink of being eradicated, and the progress from the 80s to the mid-2000s was incredible. However, unfortunately, we've seen reseeding of the virus, the wild polio virus, from endemic areas to multiple countries abroad, to multiple regions, with consequent outbreaks, which have proved both horrific in the context in which they occur, but at a global level threaten what is a cherished goal of mankind. We've only ever eradicated one disease in the past together, smallpox. We now have the opportunity to eradicate one of the most devastating pediatric diseases that there is. We have one more mile to go, and our journey is not yet done. But we are faced with re-established proven infections in other countries, and specifically we see 4 reinfected countries this year: Iraq, Syria, Somalia, and Kenya. The Middle East polio outbreak was probably as a result of an importation to the region of a virus from Pakistan. The virus, as has been said previously, has been circulating in the region since late 2013 in many, many countries. Paralytic poliomyelitis cases and disease transmission occurred in Syria in late 2013, and the disease spread to Iraq in February 2014. Our current risk assessment is that polio spread may still occur. However, huge strides have been made in the Middle East in the last 6 months to prevent this. I think we have averted the prospect of devastating outbreaks, but we have still some risk, and we need to address that risk in the coming months. Currently, the polio virus cases are spread across Syria, and 1 case in Baghdad in Iraq. As previously mentioned, the influx of Syrian refugees into the neighboring countries has provided a potential vehicle for virus to move. But that is not the only means. The virus is present throughout the region. The most likely source of a wild polio virus case entering Lebanon would certainly be from Syria, but there are other means by which the virus could emerge in this country. In response to the detection of wild polio virus in Syria, ministers from all the Eastern Mediterranean countries met in Oman in 2013. They declared a regional emergency, and immediate action was taken across all 7 at-risk countries, with synchronized and repeated mass vaccination campaigns, national immunization days, and subnational immunization days, with a focus on intense acute flaccid paralysis surveillance. It is my pleasure to bring the congratulations of Dr. Al-Alwan, our regional director, because what has been achieved, this is unprecedented, operating in 7 countries at the same time. Many of these countries in the region are suffering political and civil instability, with massive pressure on their health systems, massive movement of people in the region. It is an incredible feat that so much has been achieved so far in such a manner of partnership across the region. Our goal in the Middle East Strategic Plan, which you can find on the Global Polio website, was to detect all cases of wild polio virus through enhanced reporting and investigation of acute flaccid paralysis, to respond using large-scale and repeated immunization activities, and to prevent and sustain, control and prevent further recurrence by improving routine immunization services. We defined 3 intervention zones: 1, Syria at the time, but 2, countries like Lebanon, southern Turkey, parts of Jordan and Iraq that were close to the borders with high numbers of refugees, which we considered to be a secondary outbreak zone, a zone in which the virus was likely to be transmitting, and a 3rd area, a risk reduction zone in the rest of the surrounding countries. Again, it is hugely impressive. 28 supplementary immunization activities, 28 massive campaigns conducted across the region targeting approximately 22 million children with multiple doses in Syria, Iraq, Jordan, Lebanon, Egypt, Turkey, and the West Bank and Gaza or Palestine. The polio case in Iraq, though, scared us all. At some point early in the year, we thought maybe we're there. You know, maybe it's contained in Syria. We just have to finish, and then, boom, we have a case in Iraq. The case in Iraq actually was the result of vaccine refusal. The child's family were offered vaccination and refused vaccination and traveled, and the virus spread. It was not because the child was missed. It was not because the child was in an inaccessible area. It was not because the child was in a besieged city. It was because the child's family felt that they didn't trust the vaccine. And now we deal with having to vaccinate again and again, more immunization days in Iraq, a huge effort to try and make sure we don't see what happened in Syria occur in Iraq. The question for us all is, and for you here in particular, is could Lebanon be next? I point you to an article in the CDC Morbidity and Mortality Weekly Report. There have been multiple outbreaks following poliovirus importations in Europe, in Africa and Asia. This is not just an issue in Africa or the Middle East. We have seen huge outbreaks associated with importation and transmission of disease within countries. A good example, I think, for us all to look at is the case of Tajikistan between February and July 2010. A case of disease importation, probably from India, resulted in an explosive outbreak in Tajikistan. 460 confirmed cases. And remember, a confirmed case of wild polio virus masks probably 200 cases in the iceberg of poliovirus disease underneath. So in Tajikistan context, we were talking about hundreds of thousands of cases. 35% of those cases were greater than 5 years of age and with a much more severe morbidity or mortality profile, with an overall 6% mortality. This is the kind of polio that was seen in the 50s. This is the polio that our grandparents and our parents speak about. This is the polio of history, and not something we want to see here. And again, the outbreak was extremely intense. But of note, preceding the outbreak in Tajikistan, routine coverage for oral polio vaccination was only between 76 and 87% over the previous 3 years, and was probably worse before that. So Tajikistan was an accident waiting to happen. Tajikistan was an underprotected population connected to an endemic area, so when the disease came, it was like a fire in the dry season. It just lit up. So why is Lebanon at risk? Confirmed polio cases in Syria and Iraq. Clearly, we all accept that. Environmental samples are positive in the occupied Palestine and Egypt, and have been positive repeatedly, not just once, but through systematic surveys. There's high population movement to Lebanon from Syria, Iraq, and Palestine. Lebanon is one of the most connected countries in the world. Beirut is one of the most connected cities in the world. Lebanon is polio-free since 2002, but routine coverage with oral polio vaccine is low. By global standards, it is low. We can come on to discuss the reasons for that and the utilization of IPV, which is a very good vaccine. But it does mean that there's an exposure to risk from Lebanon for that fact. What are the key actions to keep Lebanon polio-free? It's a very simple strategy. It is the strategy we have used worldwide. We need to detect any case of polio through sensitive surveillance for all cases of acute flaccid paralysis, with rapid investigation of all cases. The surveillance system is not a polio surveillance system. It's a surveillance system for a syndrome called acute flaccid paralysis. And polio is then detected through the laboratory process within that group. This does not in any way question or to put into question the clinical and diagnostic process that pediatricians do in this country. Your intention to treat, your management, your other investigations, your therapeutic regime, that moves ahead. But we must have reporting of acute flaccid paralysis to the Ministry of Public Health as soon as it happens. And there is some data later which is not so good, which shows that Lebanon is lagging far behind the rest of the region and far behind the rest of the world in this critical area. We need to prevent polio transmission in the community during outbreaks by establishing high levels of population immunity using oral polio vaccine. It is the only intervention in an outbreak. IPV does not stop transmission, and I will talk about that in a few minutes. And we have to sustain polio control through high levels of routine coverage. Detection of polio, as I said, is based on recognizing and reporting all AFP, rapid case investigation and stool sampling, and rapid transport of quality stool samples to qualified laboratories for confirmation. This is a global system. This system costs millions and millions of dollars to sustain at the cost of the public purse every year on a global basis. We need to feed the samples into that system to be sure we don't have polio. Acute flaccid paralysis surveillance across the region is varied. You don't need to look at the numbers, but red means bad, green, dark green means good. So the issue of under surveillance of AFP or under reporting is not just an issue in Lebanon. It is an issue in many, many countries. It is an issue in many European countries, to my great frustration. That is not such an issue when you don't have virus next door. That is not such an issue when you don't have circulating virus in every country surrounding you. Palestine, Israel, Syria. It is an issue when you have that circumstance because you are blind. If you cannot see the threat, you cannot react to the threat. AFP surveillance is the eye or the eyes of response, and we'll come on to, again, talk a little bit more about that. However, having said that, and I think great credit is due to the Ministry of Public Health and yourselves, AFP surveillance is improving in Lebanon and has significantly improved over the last number of months, particularly in response to the outbreak. However, we'll come on to talk about those improvements and how we can make it even better. As I said, AFP is not a disease, it's a clinical syndrome. We try to reach a target of 2 per 100,000 cases in less than 15 years. And success of the AFP system means that physicians have reported all AFP as soon as possible, and the surveillance system can collect 2 stool specimens as early as possible from those children. It's a mistake for anyone to believe that the AFP system is to report only poliomyelitis. It is not. As I said, there have been significant improvements in surveillance in Lebanon, and Lebanon is ranking well with other countries. However, many of the cases in Lebanon are being detected by retrospective case finding, not by active reporting by physicians. The system is having to go back and look for cases, and by the time it finds the case has recovered, or the case is no longer positive for the virus, or another reason. So there are significant delays. For example, the target for AFP surveillance is that 80% of cases will be reported within 7 days of onset. And that target has been reached in most countries in the world, in most districts, and most regions. You can see for yourselves that in Lebanon, that only around 40% or less of children with acute flaccid paralysis are reported within 7 days of onset in Lebanon. This is not acceptable if you're going to protect Lebanon from polio. Equally, and again, you don't need to look at the numbers, you can see the big long line for Lebanon. Those lines represent the total time taken for reporting, sampling, transport of samples, and results. The full cycle of surveillance. Compared to the other countries in the Middle East, Lebanon has a much longer process. It takes longer to report the cases. It takes longer to do the sampling. The quality of the samples is not as good, and therefore your system is not capable of fully detecting all cases of AFP in time to make a difference. However, as I said, there have been significant and highly welcome improvements in that since late last year. And I think maybe Dr. Nada Rosen may speak on that later, I hope. So, what action do we need? Better surveillance. Surveillance is not a public health intervention. It is not a public health act. Surveillance is a partnership between clinical and public health medicine, where the reporting physician detects suspected cases, reports them to the Ministry of Public Health, and where the Ministry of Public Health investigates, collects samples, and follows up and classifies the cases. This process leads to vital lead time in detecting a polio outbreak, allowing for rapid response, allowing for rapid mop-up, vaccination and response. Preventing polio transmission, though, once imported, once you have disease in the country, is based on rapidly raising the gastrointestinal immunity of all children under 5 years through supplementary immunization activities. And this is where a question arises, OPV versus IPV. There are many arguments to use OPV or IPV depending on your circumstances. But in the context of an outbreak, OPV is the only vaccine, oral polio vaccine is the only vaccine that provides gastrointestinal immunity. While both vaccines prevent paralysis, oral polio vaccine is the only vaccine that prevents further transmission. Children vaccinated with only IPV can process wild polio virus in their guts, and they can excrete that virus, thereby infecting others. So if a child has only IPV, goes to school, is infected in a school outbreak, and comes home, that child can infect their younger sibling. Therefore, OPV is the only choice in an outbreak situation. There is no option. In terms of vaccine-associated polio paralysis, there are many, many different myths and legends regarding this. Historically, the rate of vaccine-associated polio paralysis after the first dose of oral polio vaccine is 1 in 2.7 million. That's actually extremely low. I'm sure you as pediatricians would experience adverse events for other interventions and medicines at a much higher rate than that. Actually, the POL2, the wild poliovirus type 2, is associated with 40% of that. And the introduction of BOPV, the bivalent oral polio vaccine here that doesn't contain the type 2 virus, will actually reduce that even further. Second and third doses of oral polio vaccine are associated with VAP at the rate of about 1 per 30 million. Extremely low. And vaccine-associated polio paralysis has never been documented or seen in a child who had previously received IPV, because the IPV primes the humoral system, and when the child is then given the vaccine-associated polio paralysis occurs when the virus in the vaccine reverts to a wild type and processes in the gut. If the child has already had IPV, the child has humoral protection and will not develop paralysis. So in this context, IPV and OPV combination is the best strategy for Lebanon in terms of dealing with NIDs with OPV and also for the purposes of routine vaccination. A good example of that in terms of the introduction of IPV is in Hungary. The chart there shows before 1980, 1992, the rate of vaccine-associated polio paralysis from oral polio vaccine. Once a single dose of IPV was introduced at 3 months, there were no further cases of vaccine-associated paralysis, even though OPV continued to be used. The activities in Lebanon, again, I must offer huge congratulations to Lebanon, the country, to the Ministry of Public Health, to you, the medical and pediatric associations, to have carried out 4 full-scale national immunization days in the context of Lebanon in such a rapid period is nothing short of astounding. It is hugely impressive. And the coverage rates that have been achieved, while not, they could be better, but again, in the context that you find yourselves in, I think there have been jobs extremely well done, and I think have probably resulted in a massive reduction in the risk of an explosive outbreak in Lebanon. However, and maybe Dr. Ziad might speak to this later, a lot of the research being done in the post-campaign monitoring shows that we're vaccinating the same children again and again and again. That 20% or 10% that we miss, we're missing them each time. We're hitting the same nail with the same hammer, and we're missing this one over here. So we have to discuss, hopefully here, what are the strategies to target our vaccination. Maybe moving away from national immunization days for now to a more targeted, strategic approach to find the unvaccinated, to reach the unreached. And if we're going to sustain polio control in the long term, high routine coverage with IPV and OPV is the way forward, I think, for Lebanon. I think the Ministry of Public Health's strategy is now a mixed IPV and OPV. But if we just look historically, again, the historical coverage with OPV, the third OPV dose, OPV3, is systematically less than 80% in Lebanon. And that compares poorly to other countries. However, you do have IPV, which other countries don't necessarily have. The immunization schedule is here is the MOPH one. I do know in the private sector that the focus is on IPV 4 times. I think, given that the ministry is now providing vaccine, oral polio vaccine during the campaigns, and I think we need to seriously have a discussion about how OPV could be introduced to the routine vaccination program in the private sector as well. I think this is an absolute must, and it's something that needs to be discussed, and how that partnership with the ministry can proceed. It's exceptionally important. So as I said, phase 2, the priorities for Lebanon, we have to reach the unreached. We have to have a targeted approach in high-risk areas and populations. We need to strengthen AFP surveillance, and we need to sustain high routine coverage with IPV and OPV. What we need from you is to report any AFP case to the Ministry of Public Health as soon as possible. The telephone number is up there. There are flyers and handouts that Dr. Nada has at the desk with all of the local contact numbers. We would also ask you to facilitate the collection of stool specimens. Although the Ministry of Public Health people do that, the reality is that many parents are nervous in providing samples and often seek the guidance of their physician. Please help us and facilitate it. The stool sample is crucial in order to make the diagnosis. Ensure, if you can, support us in ensuring the vaccination of all children in each campaign until our outbreak is over. And please implement the National EPI protocol of OPV and IPV. And I think that requires a much broader discussion with the Pediatric Association and with the Ministry as to how that might happen. That's not my expertise, but I would really appreciate a discussion on OPV within the private sector immunisation schedule. There's much more information on the government and the Ministry of Public Health website in terms of prevention, surveillance, the data on the current outbreak, etc., etc. I advise you, encourage you to go seek that information. And I'd like to thank you for your attention. There was a lot to cover, and I hope we can have a discussion on the key issues. Thank you.
So, this is the AFP, and the floor is open for questions, please.
I'm an allergist immunologist. So I am faced with immune deficient patients, and I am working in the Middle East, and 30% of all marriages are consanguineous, so we have a very high rate of immune deficient patients. Now the problem was raised in 2009 in India when one of the OPV patients was found to continue on secreting the polio in his stools after 5 years of being vaccinated. And as you know, when it is an immune deficient patient, the polio will become it goes back to the aggressive virulent form. And since then, publications have been found in the literature about adults actually who were never known to be immune deficient, and they were found to secrete polio in their stools for 30 years even after their vaccination. And actually we didn't know in the past, before 2010, that 60% of immune deficients are actually adults who don't even know that they are immune deficient to start with. And we know nothing about T cells. We know a little bit about humoral immune deficiency and polio. So my fear is the following. Are you actually introducing polio to the whole world instead of doing the opposite? And why are we only vaccinating here and not in Europe or in the States or many other countries, since everybody now is connected and we are all constantly moving around? It's not like every country is different than the others. We are all moving around. So these are my fears, and I would like to hear your answer to that. Thank you.
Wouldn't you suggest that adults would be vaccinated with IPV because of the waning immunity? Adolescents and adults?
Je vais parler du point de vue médecine publique dans la présentation, quelques points. Le rythme des campagnes nationales qu'on a fait, on a fait 4 en 6 mois à peu près. Est-ce que vous préconisez qu'on continue à ce rythme-là? Si oui, combien? Sinon, comment on doit faire vu l'impact actuel de la maladie au Liban? C'est encore bien, mais il faut savoir comment on va aller. Et le target des patients qu'on n'a pas atteint, vous avez parlé un point très important, parce que dans ces 20% qu'on n'a pas atteint, ou 15%, probablement on a atteint personne durant les 4 campagnes, ou bien on a atteint 4 fois la même personne. Donc c'est important de voir cette sélection et de bien cibler les enfants qui n'ont pas été atteints. Et je préconise de faire un fichier pour chaque enfant, et sur ce fichier-là, on met si elle a été atteinte, dans quelle campagne, pour voir sélectivement l'état de la vaccination.
It is a comment about the association of the measles vaccine with the polio vaccine during this last phase of the national campaign. So because these are two different diseases, and apparently the target populations were different. So this has led to a lot of confusion somehow. So if there is a way this can be done otherwise next time.
In terms of the immunodeficient patient, there's a big difference between what is a public policy regarding a standard for vaccination and what is the individual decision of a clinician faced with an immunodeficient patient. And a general policy cannot speak to that. The general policy is that oral polio vaccine can be given to all people except those who are severely immunocompromised, and those syndromes are detailed. That is not to say that an individual clinician with a particular concern for the health of an individual may decide to not vaccinate. We have to be very careful in that. But if you see a situation where multiple children are not being vaccinated because of a inverted commas label of immunocompromise, then you start to see many children missed, and then the risk of them becoming infected with wild polio virus is all the greater. In terms of your question about the global spread of the vaccine virus, part of the reason for introducing IPV around the world has been to reduce the incidence of vaccine-associated polio paralysis. But the reality in an outbreak risk situation, and please, I think you cannot argue that Lebanon is in the same situation as the USA or Mexico right now when it comes to polio. You are on the doorstep of a polio outbreak. You have documented wild polio virus in the environment in multiple countries around you. You cannot put your head in the sand and say, we're more like Ireland or the US at the moment. It is not the situation. However, it is always an issue for policy, for when a country shifts from OPV to IPV. It's a risk management decision. We can only advise the government from WHO as to what we believe to be the best policy. The government can only make the best policy decision that they can. I believe they have made the right policy decision, and the use of IPV and OPV in the current context is extremely advisable and very defensible. I would not like to be in a country where I was only using IPV in the Middle East right now. I think the political and medical consequences of such an approach would be catastrophic in the event of an outbreak, and indefensible in medical terms. And in medicine, it is always a balance between the good of the patient and the good of the community, obviously. Zia, did you want to make a point?
Okay. Again, just a couple of points. In terms of the Indian whole history of polio containment, and you know India is one of the endemic countries where polio was like having a lot of issues in terms of control. The only way that they controlled polio and declared India as a country free was through oral polio. So despite the presence of the shedding, it did not impact the outcome at the end, or the goal that we had is stopping the transmission and halting the incidence of new polio cases. As you're comparing Lebanon to America or France and talking about both epidemiological profile, we're too far from there But I can compare our situation to Israel that do not have 1.4 million refugees, and they have shifted their vaccination now from IPV to OPV, and they have conducted national immunization days. So, and this is like one of the countries that have, you know, years of free polio, and they compare themselves to European countries. So they have reintroduced again OPV in the context. So as Mike has well pointed to, it is very difficult for a country to continue staying on IPV per se in such a risk profile. So we need really to think about it in that matter. Thank you.
In an outbreak situation, the fact that you have to accept that that carriage occurs, it can actually be a benefit because the virus, actually you're spreading the vaccine virus. But I don't think that's a reason to say because of a long-term secretion of the virus that you should stop using oral polio vaccine. It's not. In terms of adult vaccination, I think that's good advice. I mean, the job of the EPI program is not necessarily to vaccinate adults per se. But if adults are not protected, if an adult has never been vaccinated against polio, they certainly should be in the context of. So if a parent walks in with a child and says, I want my child to be vaccinated, but I've never been vaccinated, well, there's an opportunity to vaccinate. So I do think that's important. But as regards the logistics and the cost and the benefit of carrying out population-wide vaccination programs for polio would be prohibitive and would not necessarily result in the benefit that we would need, given that the most intense transmission is amongst children. I think that's, and there was a point a colleague made about the multiple vaccinations and 3 and 4 doses and all that. I mean, I think in India you'll find kids who've been vaccinated 25 times.
In Bangladesh 27 times.
Yes. I think one of the things with and it's an interesting point because with the current trivalent oral polio vaccine, it's interesting that the initial immune response to the first dose is almost exclusively to the type 2, which is actually eradicated. So you actually get relatively little public health benefit from the first dose of TOPV. The ministry here in Lebanon has now moved to endorse the use of bivalent OPV. Bivalent OPV contains type 1 and type 3. Type 3 is practically eradicated as well, but we need to keep it for the purposes of good public health at the moment. But what we're seeing is a much better immune response profile. I have some graphs I could show you showing the immune response of children to the bivalent vaccine, which is much more rapid and much more protective. So I think, again, we're seeing that evolution, and we may move in the coming years to monovalent vaccines when the other one is gone. And it may result, in fact, and it did result, and in fact I think the advent of these innovations were a big part of getting rid of the disease in India to a great extent. So I think we may not have to vaccinate as many times in the future. But it's, again, the reason for doing these national immunization days and repeating them is not necessarily only to protect the individual child again and again. What you're trying to do is compete out the wild virus. You're trying to have everyone is processing the vaccine virus, and that's what you're competing the wild virus out of existence in effect. And what you're doing is creating a firewall and preventing transmission for a set period of time, which is killing the opportunity for the virus to spread from person to person. So I think that's the justification. In terms of Pakistan, the point is well made. I think you see both Nigeria and Pakistan are the sources now of almost, I think, of every case in the world, every outbreak that's outside those zones. So we have to support Pakistan and Nigeria to finish the job. Because as long as Pakistan and Nigeria have not finished, we are not finished. Afghanistan as well. But Afghanistan has done extremely well. Afghanistan has made amazing strides in the last year or two, and is to be greatly commended. But we all understand that the political situation in northern Nigeria, the political situation in northern Pakistan is such in terms of violence and instability, and we all know historically instability and civil strife compromise the capacity of health systems to do their job. And polio is not eradicated, not because we don't have the right tool, not because we don't have enough money, not because we don't have a good health system, not because we don't have good doctors, not because we don't have brave vaccinators. Polio is not eradicated because there is not the political will and there is not the ability to stop fighting and the ability to accept the vaccination and communicate with those local leaders in order to do that job. So it is an awful situation that we have the tool, for once, we have the tools and we have the money, we have the capacity, but we don't have the access. And that is a tragedy in 2014.